Do I press on?
Okay, good morning, everybody, and thank you so much for joining us for another one of our MAG Meet the Specialist sessions. These great little sessions where we get a snapshot of what the specialist is like in person, so you can think of them more as a person and not as a expert somewhere. Today we have the very wonderful Dr. Peter Gray, who is an orthopaedic surgeon. He specialises in hips, knees and lower limb trauma, including pelvic trauma. He has worked for over 30 years in the public and private systems. He also assesses children, which is quite rare, we find anyway. Dr. Gray has been with us at MAG for many years and he's one of our longest serving and almost a founding doctor with us. We love to work with him and his reports are excellent. Dr. Gray provides us with regular availability as well. So I will, hand over to you, Dr. Gray, to have a bit of a chat about yourself and what you do. And then at the end of it, people can ask a question if you have a question to ask. And we'll see how that goes. Thank you so much. Over to you.
Well, thank you, Michelle, and good morning to those listening. Apparently there's a problem with timing, but let's not worry about that. So as introduced, I'm Peter Gray. I'm an orthopaedic surgeon, retired from clinical practice, and now a consultant independent medical examiner. As this is a Meet the Specialist session, my talk will centre around the how, the why, the when, and the where I came to this point. I graduated from the University of New South Wales in 1975, and as an intern at St Vincent's Hospital, I was exposed to the practical on-hand nature of orthopaedic surgery. 3 days a week, there was a fracture clinic. After each clinic, we'd head down to the plaster room, where I strove to create the perfect upper limb and lower limb plaster cast. I thought I got pretty good at it. I certainly enjoyed myself. I was subsequently appointed to the St Vincent's surgical program, 18 months of cardiothoracic surgery and 12 months of vascular surgery, honed my surgical technique, but did not evoke the same passion that I gained from orthopedics. I was fortunate to be accepted onto the 4-year Australian Orthopaedic Association Advanced Training Program in Sydney in 1981, gaining my fellowship in 1985. My aim was to pursue a career specialising in the operative and non-operative management of disease and injury of both the hip and the knee joint in children and in adults, an holistic approach from the cradle to the grave. A 2-year fellowship in hip and knee arthroplasty in Sydney, followed by a 6-month Paediatric Orthopaedic Fellowship in Hong Kong, and rounded off by a 6-month Arthroscopic soft tissue and knee surgery fellowship in Sydney, further prepared me for the task ahead. I worked in both the public and private sector, with appointments at the Mater Hospital, the Sydney Adventist Hospital, the Norwest Hospital, the Children's Hospital, initially at Camperdown and subsequently Westmead, and the Ryde Hospital. I retired from surgical practice after turning 65, as I believed it appropriate and I could. Those 35 years were an amazing time to be an orthopaedic surgeon, associated with great changes and developments I could not have envisaged while I experienced the joy of working with plaster. I haven't gotten close to applying a long leg cast for over 20 years. In the late 70s, comminuted femoral fractures were treated in traction in hospital for up to 3 months, and then 3 months further to regain any range of knee movement. Today, with the use of intramedullary nails and cross-screw fixation, inserted minimally invasively often, that same patient can be out of hospital, partially weight-bearing on crutches, moving their hip and knee joints within the week. When I commenced my orthopaedic advanced training, meniscal injuries were treated with open incisions, usually about so big, followed by 10 days hospitalization. Now, even multi-ligamentous knee reconstructions can be treated arthroscopically with day-only surgical and post-operative care. Progress has been driven by the adoption and the adaptation of fiber optics, video screens, MRI scans, the design and application of small surgical instruments, but more importantly, the imagination and vision of surgeons who, over time, developed techniques to apply all this technology. Joint replacement surgery, rarely performed when I was first introduced to orthopaedics, has grown and developed enormously. Over 52,000 hips, 68,000 knees, and almost 9,000 shoulder replacements were reported to the Australian Orthopaedic Association National Joint Replacement Registry in 2021. Hurdles have been experienced and overcome along the way. An early, unappreciated issue was the destructive effect of polyethylene bearing surface wear debris on bone. Implant failure was often associated with large bony defects, challenging the revision surgery. When I was a registrar in my final year of training at the Rachel Forster Hospital in Redfern, the precursor to what is currently the Institute of Rheumatology and Orthopaedics at Prince Alfred Hospital, femoral heads removed at the time of a hip replacement in one theatre were transported in a sterile fashion to the theatre next door, where it would be used as bone graft to fill the large defects prior to implantation of the revision implants. I was fortunate enough to be in the position to establish the first bone bank in New South Wales at the Rachel Forster Hospital, where we could store all the resected femoral heads in a frozen state to be used whenever required. National tissue banks now exist as a source of not only femoral heads, but whole bones, ligaments, and even procedure-specific grafts such as bone, tendon, bone grafts, which are used in revision of anterior cruciate ligament reconstructions. This tissue is now harvested from organ donors at the time of heart and kidney retrievals. Joint replacement surgery has been driven by its success in relieving the painful immobility of osteoarthritis. Over my 35 years of clinical practice, I have witnessed and participated in great changes. The constant re-evaluation of performance and the application of technological advances have resulted in improvements in implant construction and design, improvements in the durability of ceramic and polyethylene bearing surfaces, and developments in operative technique. With regards to the latter, the performance of total knee replacements, with regards to the latter, in the performance of total knee replacements, we have evolved from using a builder's plumb bob, I presume you know what a plumb bob is, string the ball on a stick, to assist in assessing alignment, through to image-based, robotically assisted computer navigation. This technology can now more accurately assess and assist the current trend of kinematic alignment. Now, the fact that we've used builders' equipment is my rationale for going to Bunnings to see what other thing I can find there that may be used to innovate some new changes in orthopedics. Some people don't believe that's why my motivation. But anyway, I go on. As much as I loved my operative clinical career, all things must come to an end. For the past 7 years, I've been working as an independent medical examiner, dealing only with disease and injury of the hip and knee joints. Now, when I consult, I stress the word independent. I inform those sitting in front of me. They may like my opinion, they may not. Their employer, their insurance company, their solicitor may like my opinion, they may not. None of the varied responses concern me. I have to like what I write, but more importantly, I have to be able to defend the opinions if the matter goes to court. Under such circumstances, if my opinions are rubbish, I'll be quickly found out and discredited. In that outcome, both the patient sitting in front of me and myself were wasting our time in the whole process. My opinions are based on the training, education, and experience of the 35+ years I have recounted. I could go on, but such monologues get tedious. I trust I have given you some idea of the terrific journey I've experienced and my current status. Thank you for your attention.
Thanks so much, Dr. Gray. It's funny that you said that about going to Bunnings, because another surgeon friend of mine refers to orthopaedic surgeons as the tradies of the medical practice.
Yes, but look, I think you should. We are carpenters, but then Jesus was a carpenter.
Exactly, absolutely. Look, before I open up for the other people to ask a question, I have two questions that have come from people who are unable to attend. And the first is, given your years of experience, Dr. Gray, do you find a shift in attitudes in relation to going ahead with surgery versus attempting a non-invasive form of rehabilitation or therapy prior to surgery?
Look, that's an interesting question, and one that I'm struggling with at the moment. When I was in practice, I was most reluctant to offer a knee replacement to people under the age of 65, under the age of 70. And I'm now seeing people in their 50s getting knee replacements. Now, the Australian Orthopaedic Association National Joint Replacement Registry, which I spoke about, has now got 20 years of experience, and knee replacements are performing much, much better than I ever thought they would. However, at 20 years, there's still something like, well, it varies implant to implant, but something between 4.5 and 8% failure rate. That's just that's those that come to revision. What we don't know in that is who's happy. And when we look at patient-reported outcome measures, we see that only about 85% of patients are really happy with the knee replacement. And one of the things I've noticed since doing this work is that I used to think I was pretty good at replacing a knee joint, and I thought all my patients were pretty happy. And and then I come and do this work, and when I assess under the whole person impairment, I'm pretty lucky if I get better than a fair result for a knee replacement, which ends up as a 30% whole person impairment. And I'm thinking, gee, we didn't go really well, but I thought we had. Anyway, so the answer to the question is, I still think we should. And also the other thing from joint, all this information we have, it would appear that patient-reported outcome measures, the percentage of people who are very happy, if they're over 70, they're very happy. Less than 65, they're significantly less happy than those that are over 70. And I think that's because maybe we as surgeons are selling the wrong information, in that we're happy to do the operation, but perhaps we don't give people the right answer. A knee replacement is a great operation if you're 70 and you want to walk to the street, have a cup of coffee, read the paper, even walk around the golf course, hit a golf ball. But it doesn't really help the miner who is wearing gumboots, standing in sticky mud down a mine at the age of 52, who's looking at another 15 years of work. And I don't know whether they're going to stand up to that treatment. So but that's a personal bias. However, the problem is we have someone in front of them who says they can't do anything, they're not doing it, they can't get out, they can't walk. We know a knee replacement can give them that ability. All the other options, what are there? Well, if you've got advanced changes, and I mean advanced changes, one of the other problems I see is I see a lot of people fronting up for a knee replacement now without weight-bearing x-rays. They're done on an MRI scan. And MRI scans can show, full thickness wear changes, but you take an x-ray and the joint looks normal. And I certainly wouldn't want to do a knee replacement like that. I'd be very embarrassed when I was operating, if I had an x-ray up on the screen for everybody to see where you could still see a joint space. I was most embarrassed by if I did that. Maybe I waited too long. Maybe people suffered. Maybe they went off and saw someone else. I don't know. But there's a limit to how much you can, torment patients by not operating. So it is a mixed issue. I have lots of concerns. And if there are any, what I'd really like to do, and if there's anybody out there listening who in an insurance company, I'd really love to look at all the people that have had knee replacements, the type of work they do, and who goes back to work to do that work. There's very little information in the literature on that, and I'd really love to look at that. And so I'm happy to come in free of charge to review all that information so that I can get some idea on where it's all going. But look, there are many. I'll rattle on because I can, because no one's listening. Just you.
We're going to have to wind up, sir. We do have a couple of people on the line.
Okay, that'll do. That'll do.
No worries. Sorry.
Don't ask another question.
Our other people, well, you actually answered the other question that I was going to ask. So as part of your answer there, our other two people on, do you have a question you'd like to ask? Isaac or Ms. Lynch? No? Yes?
Oh, I was just going to confirm that. Yeah, no, I'm good, but I did find that last question interesting too, about to replace or not to replace at certain ages. So, quality of life versus, and again, just at that final point that Dr. Gray mentioned, the whole, it would be interesting to see what statistics were allowing people to go back to their pre-injury duties after replacement.
Absolutely.
Very interesting.
Look, thank you all so much for making time to join us today. And I know that this seminar will be watched online. The recording will come out to you, those who have registered, within about a day. And I hope you go and have a wonderful rest of today. Thank you again, Dr. Gray, for your time. Really appreciate it.
Michelle, thank you. Thank you. Bye. Thanks.